Good afternoon, everyone. Thank you so much for being here. My name is Kendall Ho. I really want to welcome you to the ICON VCH Indigenous Health Round. Really excited to have you all here. And we have a wonderful program with excellent presenters and elders leading us through this session. So I'm personally very excited about that. I'd like to first do a land acknowledgement. I'd like to acknowledge that this session today occurs in the shared and ceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And I welcome you. If you would like to use the chat function to acknowledge where you are currently, we'd love to welcome that. And thank you so much for doing that. And I just feel very fortunate as a settler here to be able to enjoy the land I have here as an invited guest. And I welcome you also to do that. My name is Kendall Ho. I am the Executive Director of Intercultural Online Health Network, a program under the UBC Faculty of Medicine, Digital Emergency Medicine Unit. And I'm very fortunate that this round is actually in partnership with the VCH Indigenous Health and also with BC Ministry of Health. But before we go any further, I'd like to really invite Elder Dennis Joseph. We're very fortunate to have Elder Dennis Joseph to be here to begin our session with first an opening prayer. Elder Dennis' ancestral name is Xwechtaal and is of Coast Salish heritage from the Squamish Nations. He's traditionally trained speaker in the Coast Salish Longhouse, has been master of ceremonies at many gatherings, and is a wonderfully reliable community support and really a pillar support during the times of need. So Elder Dennis, thank you so much for being here. Let me invite you to help to guide us with the opening prayer.
Thank you, Kendall. In a moment, I'll begin in a language, but I really want to lift my hands up to all of you for arriving here today. Xwechtaal Kushaman, Osiam Hoicho Chachachanek Chasiam. What I would like to invite all of you to do as I share my prayer, to invite your good thoughts and even a prayer in your heart and mind, as I would like to dedicate this prayer not only to those in this room, but also we're falling upon Veterans Day. I would like to dedicate this to all of our veterans from the four directions, many of who are gathering to celebrate, maybe who were held arms against each other many years ago. In particular, I want to dedicate it to my cousin brother who left us almost 2 years ago today. He served in the Canadian Army, went to Afghanistan for 8 terms or 16 years, a communications specialist. And he left us suddenly on the commercial drive, having a cup of coffee with his Army buddy. He was one of 1 percentile in Canada in the Army that served for 31 years, 10 months. And he was 2 months short of that 1 percentile to have served that long. A staunch warrior, like all of our warriors, men and women. Osiam Hoicho Chachachanek Chasiam and Hot Coats and Stomo. Hoicho Tisha Okomeo and Hot Munt Tumakwitsi Kutsnachum. Hoicho Staunch CEMs, CEIs and Slanis and Hot Swallowing. Giving thanks to the Creator, all of our ancestors who've gone before us. I'm grateful to friends and relatives from the four directions gathered here. We ask for blessing for all of our veterans who'll be gathering soon. For the veteran we just lost suddenly the other day, we put away from the RCMP and their families. For any prayers and healing prayers in our hearts and minds that the Creator hears them. Tumakwitsi Kutsnachum Stomo and Hot, all my relations.
Thank you so much, Elder Dennis. What I'd like to do is do a quick introduction about the agenda for today, and then I'll have opening remarks following that. What we'll be doing is that, as usual, we will be momentarily starting the session after the two opening remarks from Vancouver Coastal Health, Indigenous Health, and also from BC Ministry of Health. And then we'll go into the substance of the discussion, and we'll have the presentations by Elder Dennis Joseph and also with Laurie Quinn. And then we'll open up for Q&A. We likely will have at least about 10 minutes of interactions before 1 o'clock. I know that many of you may need to leave by 1, but this session is actually open till 1:30. So if you want to stay, you can stay. You're very welcome to stay till 1:30. I'm very glad our speakers and our elder will be staying till 1:30 for dialogue and interaction. I also hope you're okay that we will be recording this session. As many of you know, the previous sessions, I personally learned so much. We want to make sure that we share them. And so we put the session on our website so other people can listen. And that's a reason for the recording. So I just want to make sure that you're aware of it as we record these sessions. But really welcome your questions, thoughts, comments for sharing. With that, I would like to then invite Dr. Brittany Bingham. Dr. Bingham is the Director of Indigenous Research in the Indigenous Health at Vancouver Coastal Health. Dr. Bingham, wonderful to have you here. Let me invite you for your opening remarks.
Thank you, Kendall, and good afternoon and welcome everyone. I want to welcome you all to this virtual circle. I'm very happy to be here today. My name is Brittany Bingham. I'm of mixed ancestry and I'm a proud member of the Xwechtaal Nation, which is on the Sunshine Coast of BC. I'm a community-based Indigenous health researcher, and for work, I'm the Director of Indigenous Research here at Vancouver Coastal Health in the Indigenous Health team. I also have another role at the Center for Gender and Sexual Health Equity, leading Indigenous health research there, and my faculty role is with the Division of Social Medicine at UBC. I also like to introduce myself as well, more personally, that I'm a mom of 2 young children, aged 12 and 8. I'm a wife, I'm a sister, and I like to call myself an academic auntie to the students that I'm lucky to work with and work alongside, and of course, a friend and a colleague to many. I also want to acknowledge that I'm zooming in today from the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh peoples, and thank you so much, Kendall, for doing that land acknowledgement. I want to extend my heartfelt gratitude to you as well, Kendall, for this work and leadership that you're taking in organizing these important sessions and these important learning opportunities and working in partnership with our team at Indigenous Health. So I have the great honor and privilege of introducing these 2 amazing speakers today, Elder Dennis or Xwechtaal, and Laurie Quinn, who's our director on our team of patient experience and quality, patient experience, professional practice and quality. I've been grateful to work with these 2 and alongside these 2 in various different capacities. So I've been lucky enough to work with Elder Dennis as part of our VCH Cultural Safety Implementation Project more recently. And Elder Dennis has been integral in this work in supporting staff on their learning journeys, their cultural safety journeys, and supporting these sessions. And, you know, that's also in addition to all of the amazing work that Elder Dennis does for many years, supporting patients in hospital settings and in clinical settings, and really working hard to improve our Indigenous patients' experiences and care that they receive in Vancouver Coastal Health. And this support is so essential, not only for the patients, but for families and communities, and also improving experiences for providers. And I'm lucky enough to work with Laurie Quinn on our Indigenous Health team as well, as a colleague, as another director. Of course, Laurie is a senior professional in this space, a senior leader in Indigenous health and nursing, and has been really leading the way and leading the charge with our cultural safety work and patient experience improvement work over this past year. So I've been grateful to learn from Lori and work alongside Lori all of this time. So I'm very excited for this important talk, and this talk is so central to all of the work we're doing in Indigenous health. A lot of our work is focused on how can we best make improvements directly for Indigenous patients as they navigate our systems of care, and make sure that we have that context of the colonial history and all of the barriers that our Indigenous people and patients face when they are accessing healthcare. So working hard to make things better every single day for our patients. So I'll pass back to you, Kendall. Thank you.
Wow, thank you so much, Brittany. A great introduction of the session, and obviously really appreciate your work, your leadership, especially on the Indigenous research portfolio, and thank you for sharing. Thank you so much. Let me now invite Sherry Barr. Sherry, I've also the pleasure of working for many years together. She's the Senior Provincial Primary Healthcare Advisor in the Primary Care Division of BC Ministry of Health. Sherry, let me invite you now to give some opening remarks to the session.
Hi, thanks, Kendall, and thanks, Elder Dennis, for the opening prayer. Much appreciated. Thank you for the opportunity to provide an opening welcome today to the Indigenous Health Round on Indigenous Patient Experience in Healthcare. I think it's an incredibly important topic. My family immigrated to Canada about 3 generations ago, depending which person, and they wanted to experience better life and get away from wars, dictatorships, and all those other events that unfortunately are still part of the world today. And I would like to acknowledge and offer respect to the Lekwungen speaking people on whose traditional territory I'm located on today. In the Salish, Songhees, Esquimalt, and Wasanic peoples territory whose historic relationships still continue to today. I'd also like to acknowledge the Métis chartered community in this area. I'm very grateful to live in such a beautiful and peaceful part of the world. Patients as Partners, where I work in primary care, believes that we can make the health system better when patients, families, healthcare providers, and community partners all work together. We have a website, patientsaspartners.ca, that describes free educational events. I invite you to go take a look at it after this. We have events such as ICON's upcoming multicultural chronic disease self-management events, and there's some that can benefit you and your patients. As Kendall said, we've known each other and worked together for quite a number of years, over 10 years, where Kendall has been the executive director of ICON for all of this time. And ICON's approach is to work collaboratively with multicultural and Indigenous partners. They work to listen and understand before developing resources and hosting events such as today. And that's a philosophy that we believe and follow in Patients as Partners overall as well. Even before the TRC was developed, Kendall had come to Patients as Partners with the idea of how to incorporate traditional Indigenous healing into Western medicine. And we thought that was a great idea, and we asked ICON to start exploring that work. And that's evolved and expanded to these learning rounds today. And as we saw in the In Plain Sight report, there's still much more that we all can do to eliminate racism in healthcare and to achieve reconciliation. And I look forward to today's presentation on understanding the Indigenous patient journey. I think through listening and learning from Indigenous stories and experiences, That is a useful step that we should all be taking to improve this health system. And thank you very much to our presenters, Elder Dennis and Lori Quinn. I very much appreciate your time and look forward to learning from you. Back to Kendall.
Sherry, thank you so much. Really appreciate this partnership with you and BC Ministry of Health, and Brittany, wonderful partnership with you and Vancouver Coastal Health, Indigenous Health. Let me immediately now go to our presenters and elders. I'm so excited, Elder Dennis and also Dennis Joseph and Lori Quinn. Let me pass the microphone over to you. In the meantime, for our participants, again, thank you so much for being here. And as we go forward, please use the chat box to type in your questions, comments, and I'll be keeping a close eye on those to make sure that when we get to a Q&A, we'll get started right away with your questions. So with nothing further ado, let me pass it right over to Elder Dennis.
OCM, thank you, Kendall. I want to thank you for the land acknowledgement, and I want you to know I really appreciate that. You know, as a traditional person in the Coast Salish Squamish ways, that's a way that's been practiced since time immemorial, coming from warriors of peace, and as is the human experience. You know, there were challenging times historically, even before contact, but always ways to work towards together as a human family. Our waterways and rivers were our highways, and that's the way we travel. And along the way, we had warrior points and meeting points for people that traveled short and long to be here for ceremonies often. Peace accords were often struck through arranged marriages, for example. But the underlying question always is, who are you and why are you here? For people who are protecting our community at different times. And this practice is still echoed in our longhouses, which in Coast Salish territory just opened very recently. And it's always done with honor and respect. People who travel the furthest get places of honor in our longhouse, and they'll work our way around as you work your way closer to home. Our host families sit the furthest away from those who traveled the furthest. And times of celebration, those who traveled the furthest get to celebrate first. Their songs, their dances, their spirit, if you will, especially in all those ceremonies that we have, weddings, memorials, namings, puberty rites, the list does go on. And the one thing really strong teaching I want to share with you all is when we gather like this, there's a peg outside our doors. And if any of us have any hard feelings for one another, put your hard feelings on that door. But when you enter these doors, you're here to work and work together with one heart, one mind, lots of mind. And when we're done, and when you go out those doors, you could pick those feelings up again, or you could just leave them on the peg. OCM, thank you. Thank you for the land acknowledgement.
Thank you, Elder Dennis. There's always teaching with you. Thank you for sharing that. And thank you for grounding us in that beautiful prayer. Kendall, thank you for always being such a strong partner with us, and for inviting us into this circle today. And Brittany and Sherry for welcoming us into this conversation. Really, that's what this is. And so we're going to talk about patient experience, and the importance of experience on patients and families and communities and on providers in healthcare. I think, you know, there's a lot of literature out there now that shares that experience accounts for more of the outcomes and the impacts on patients than that clinical intervention. And so you see health systems really groaning to move towards understanding patient experience, but still caught up in our clinical systems and our performance indicators. And so this is a conversation about experience, the impacts that we have elders have on our patients and families, and what we can look at, particularly from an Indigenous patient lens, that really matters to Indigenous patients. So that is our topic. And I was going to talk about a land honoring, but I feel like we've really expressed our honor to this land, to the people that have been here before us. And I am thankful for this rain. Who knew that I would be saying that living in Vancouver? But the rain brings renewal for the land, and I am very thankful for that. And I think that the words spoken before were beautiful and acknowledging and self-reflective. And so thank you for that.
Thank you.
We always like to start with an intention setting so people can ground themselves. We've been grounded by beautiful words and prayers and a teaching already. And so again, we're going to talk about some really important topics, but some of them could feel hard and you could feel them in your heart. And our intention is to create an environment where you can ask questions, you can feel safe, you can feel brave, and that we hope you will agree to that and join us in this conversation.
Yeah, I wanted to add always my own personal intention. I always share in moments like this. And even when I did the work back in Squamish, my intention is to support, uplift, and let go for now until next time. There's no word for goodbye in our language. And it may not be this elder's face, maybe another elder's face or another person, an elder from another culture. I'm sure many of them carry the same teaching. Thank you.
So, Elder Dennis, do you want to tell us a little bit more about yourself?
Yeah, I'll just add to the kind introduction. On the health side, I played lacrosse for 54 years, 5-time national champion, very proud of that, including an MVP. But when I worked for Squamish Nation, I always describe it as a traditional coroner. I did that work for Squamish for over 20 years. A first responder, if you will. And when somebody passed at home, hospital, or accidents, it was often there first in our communities. And along the way, helped build bridges with local police forces, coroners, ambulance services. Volunteered as a peacekeeper for 25 years, looking after our villages. Our main goal is to keep hard drugs out of our community. Retired from that work 7 years ago. Currently a musician, a lyricist, aspiring recording engineer. I keep busy. Yeah.
Thank you, Elder Dennis. So my name is Lori. I've been introduced by some lovely people today. I am a nurse. I am from the Dakota Sioux Nation on my mother's side, as well as English, and mixed ancestry on my father's side, Irish and Icelandic. You know, when Brittany was sharing her personal story and what you just heard about Elder Dennis, that personal piece, that experience, that connection, that relational piece, is really important, and why we introduce ourselves like that, and why in healthcare it's really important to really begin to know the people that we care for and that we work closely with. So my most important role is Auntie, and you can see in my photos there, I love those little humans, and I feel compelled to help grow them, that my role is to encourage them and support them. And I really bring that into my work as well with my teams. I feel like Brittany said, and Nancy in the work. And so my hope is to wrap around my team, support them, have some hard conversations sometimes, but to know them and know how to support them. So Auntie is my most favorite role. Sometimes like to say cool Auntie, I don't know. Also sister, daughter, niece, cousin, friend, and colleague. Professionally, I am a nurse. I have worked in emergency critical care and trauma for almost 20 years. And this just over a year now, I've been working in Indigenous Health, and I'm very honored to work in this really amazing work of patient experience, professional practice and quality. I am just the interim director and support for the Indigenous cultural safety programs, the elder program, and the Indigenous nurse practitioners who are out in those primary care networks serving patients and families. So that's a little bit about us. These are a few things that we're gonna kind of walk through with you today. Really an understanding of why we're doing this work. Some of those reports have already been referred to in plain sight, TRC. We're going to talk a little bit about the importance of patient experience in healthcare, and then an introduction to these emerging Indigenous domains of a culturally safe experience. And Brittany's team really led the way in our partnership together around pulling out these domains and partnering with Experience in Care, VCH, to really figure out what's the real meaning and how do we apply this to the work we're doing in a meaningful way. So it's not simply an intervention. It's a little bit different work, and it's really important work, and it takes a bit of time. So looking forward to sharing some of that with you guys today. This is our.
There we go.
So this is one of our visions as Indigenous Health at VCH, and it is this understanding of what is meaningful reconciliation, where that comes from, why we're doing that. And so reconciliation is defined as the restoration of friendly relations or the action of making one view or belief compatible with another. Many view reconciliation as a new way forward in Canada, and the term has come to describe attempts made to raise awareness around colonization and its ongoing effects on Indigenous people. The work of the Truth and Reconciliation Commission began in 2007, and after 6 years of gathering information, traveling throughout Canada, listening to over 6,500 witnesses, hosting 7 national events to raise awareness, share, and honor the experience of residential students and families, survivors. The findings were presented in Ottawa in 2015 with 94 calls to action. The In Plain Sight report released in 2020 that was referred to was around addressing racism in healthcare in BC. And it revealed that there is ongoing, current and present racism in our health systems today that impact patients and family, harm patients and family. And so that report made 24 recommendations and calls to action, and it catalyzed the focused effort in transforming healthcare. In 2021, BCCNM, so the College of Nursing and Midwives, and the College of Physicians and Surgeons developed, through collaboration, a standard of practice on Indigenous cultural safety, cultural humility, and anti-racism for all registrants. It's part of our calling as providers, why we're called to this work, which is really a good action to make. So with those calls and the calls to action, the TRC and In Plain Sight, we have an unveiling of truth, an essential step towards reconciliation. And so now we want to spend time reflecting on our own journey with humility, on our work that we do and our call and responsibility as leaders. So as we move through some of the concepts and topics, we just ask that you really think deeply around how you can be a part of this journey towards reconciliation in healthcare.
Yeah, such an important step. I always like to share my stories and my ways to reconciliation personally. I'm a godparent to my colonial best friend who has Canadian roots, English roots, Irish roots. I got to meet his daughter for the first time when she was 4. She's now turning 20. When she was turning 10, she tugged me on my shoulder. I turned around and she said, "Would you be my godfather?" And I said, "Wow, yeah. Would you like to do it in a church, or I could host a ceremony?" And she said, "No, that's good enough. You're my goddad now." And she turned and ran off to play. Did the same thing to my wife. And we still treat each other that way today, like she's one of my children. stay in contact all the time.
So these are some of the reports, the really important reports around calls to action and sort of the basis for the work that we're doing here at VCH in Indigenous Health, and what I think what many health systems or systems that serve the public should be basing their work in. So just a little look at that. So in part of our calls to action, what VCH has done, led by Leslie Blanchard, is that they have developed a whole system with specific important components of the work in healthcare and have built out a whole team. And this team in the last year has grown from quite a small group. You know, Brittany was one of the first founding sort of members here at VCH in Indigenous Health. I think it was a team of 4 or 5. And today we were just discussing this team is now built out to 70. And that is a real commitment to this work. And that is an action step forward in how we are building this, threading this through the health system here at VCH. And so very grateful for the opportunity, grateful for leaders who have been walking this talk for a long time. Grateful to elders like Elder Dennis. Elder Dennis said this beautiful thing. He said, we are patient people. We've waited hundreds of years and we'll wait hundreds of years more. And I think it's happening.
It is, and often share this in our cultural safety trainings. Having done a lot of them in my tenure, never thought we'd get this far. I quickly wanted to speak the model that's up, and it's, to me, of course, a hierarchical model that used to exist for at least Coast Salish. But one thing I've always appreciated in my tenure here in 2.5 years is the teamwork that goes on. In my corporate world, there was a lot of siloism. I see less of that here. Much teamwork goes on, and we're doing it today. It's something I deeply appreciate. Yeah. Thank you.
Thank you. So what is Indigenous patient experience? And what do we mean by humanizing care? Patient experience is the sum of all interactions shaped by an organization's culture that influence patients' perceptions across the continuum of care. That's a statement from the Barr Institute. There are 4 aspects to this fairly simple definition. Interactions, experience is based on human interactions, personal and clinical, and connections. It's grounded in culture. The kind of organizational culture we build is the means by which we deliver those interactions. And it happens at all touch points across the continuum of care. And also the spaces in between. And ultimately, the perceptions of patients and families and their support networks are the indicators of our success and experience. We cannot humanize care for Indigenous people without acknowledging and committing to restoring what once was. This is an act of reconciliation. I sort of pause on that statement because why we talked about reconciliation in a very brief definition, but it is not something new. It is restoring what once was back into a system, because what once was taken. And we have taken care and we've removed that human element because of lots of different pressures of busyness, too many patients, not enough people to provide that care. And so how can we make time and make space to have those real connections and restore both that humanized approach, but also what matters to people, what matters to Indigenous patients and families. Cultural safety is not an outcome that can be defined, not by the provider, but by the client or patient experiencing care, which helps to shift the power dynamics from provider to client, acknowledging cultural values as valid and restoring self-determination. By listening to people using a relational approach and storytelling, that's allowing people to share their experiences, we can begin to appreciate their feelings and perceptions of care that impact the health system has on all the well-being of those it serves. We know that experience accounts for more impact, positive or negative, on patients and families than simply providing excellent, clinically competent care. And I think we're really starting to realize that and trying to figure out how we can take the experience and apply it to what we're doing really well, which is applying those interventions.
Yeah, one thing I see coming is the opportunity to work with these notes here on the provider side. With political shifts happening to put forward more providers for the system, it's going to allow people to work with more time. As people get de-stressed and get more grounded, they can spend more time with the patient and the provider. I know, I'm sure all of you are under a lot of stress right now. I want you to know that it's appreciated and understood.
So what is patient experience? Healthcare is the business of human beings caring for human beings, and yet we often reduce it to body parts, diagnoses, labels, silos of care, and so on. So how do we consciously protect the human part of healthcare? Human experiences in care are strongly relational and relationship-based across every interaction along their journey. Every single one of us contributes to care experience, no matter what their role is within the organization. Do anything?
No, I can keep moving. I look forward to questions, really.
Okay, so this is just a reminder of the commitment to human experience and Indigenous cultural safety. This was the declaration of commitment that was signed throughout the health authorities in BC. This declaration was based on guiding principles of cultural safety and humility. And so I like to bring this up when people, are feeling like, oh, it's just another thing. Do we have to? Those types of things, which happens in the stress of work, particularly after 2 years of COVID or more. And so this is just a reminder, we have made a commitment and now we need to take that commitment and action it. So what we're hoping to move towards is we're going to talk today about these Indigenous domains of health for Indigenous culturally safe experiences. And so we presented this work at a think tank and got some really amazing, brought some leaders together and had some really great conversations, meaningful conversations. And so how we take a construct like the experience framework on the right and pull in these Indigenous domains of healthcare. So being grounded in the mindset that cultural safety is an outcome, we must commit to developing Indigenous-specific patient experience tools to measure cultural safety from the perspective of a patient, which aligns with the findings from the Implant Site report. To date, despite these calls to action, there's been no development of standardized indicators that are developed in collaboration with Indigenous people. Health systems thrive on data to drive progress or change, and yet we still struggle to capture how to measure an experience so that we can insert this metric and make systemic change. Indigenous research, like I said, led by Dr. Brittany Bingham, pulled from a comprehensive lit review and identified these domains in the Indigenous culturally safe experience. So we're going to talk a little bit about each one of these and how, a story to share the impact of each one, and then a conversation sort of moving forward and really looking at how are we, how are we applying these concepts to the work that we're doing in health systems? And if are we doing it? Are we not doing it? Is there a gap? Are we doing it? And is there harm? So that's really where we're hoping to dig in with you guys. There are 7 domains. This is the 7th. It's health system utilization. And it is the overall experience of all of those concepts, those ideas, those domains in the entire journey. So the Indigenous domains of health are meant to be used as a vehicle to restore what was once embedded in health systems. And like I said, I want you to think about how the health system could wrap around these domains and lenses rather than applying them to the current system. I always think, we heard so many times in COVID, we can build back better. And sometimes I think maybe now's the time to build back different rather than better. Maybe we should make that system, that construct different. think that's it. We're going to go through the 6 in a little bit more detail. Do you have any thoughts on this?
Well, you mentioned COVID and the time to slow down, and it's something as Indigenous people we've become aware of, and it's been talked about many times. Spanish flu, smallpox, but in the last few years, what I noticed with Mother Nature is a rebuilding, less cars on the road, fresh air. Some birds I haven't seen in 30, 40 years started showing up in my neighborhood. Quality of water, to me, got better. So when we slow down, Mother Earth will respond.
Yeah. I'm going to ask you how we should slow down. That's going to be my question for you, Elder Dennis, at the end.
Yeah.
I have that immersed nurse in me. I just want to go, go, go sometimes.
Mm.
So the first domain is respect. Respect involves the feeling of being valued and one's dignity being upheld by a healthcare provider and healthcare environment. This eagle symbolizes respect, honor, strength, courage, and wisdom. Since colonization, Canadian socialization has taught us that Indigenous people are not valued for their knowledge, ways of being, or experience. The prejudice has been woven into all of our systems, including healthcare, and many of us are just unaware of that learning. Add to that a health system where clinical interventions have often been done with consent in most cases, but to patients, a system where the healthcare provider knows better. So this domain is about restoring respect to the individual. Here's a story for you. This involves a patient who went from a rural remote community to a higher level of care. The patient was unwell and requiring critical intervention. After a lengthy stay in hospital, the patient continued to experience a lot of pain. A decision was made to treat this patient without their knowledge, a decision to withhold a type of pain medication and instead use a placebo. Was it a test to see if the patient really had pain? Was it a lapse in judgment or a belief that one knows better and more than another? How would you feel after the disclosure of the event took place? Would you feel like your life, your person, your pain, or your experience mattered?
In my tenure at Squamish Nation and support work, a young couple had come to my door. Mother clearly was child, and I was going to offer congratulations, and by the look on their face, I knew something was wrong. And baby was diagnosed stillborn, going to be stillborn. And they asked me to attend with them at the hospital. And I said, would your families be there? And they said, no, we just want you. Respecting their privacy, I attended most of the day with them. Sat with the dad during the process. Joined mom for a few hours after. And at the end, I assured him that I would assist in the transport of the loved one to the funeral home and oversee that from the hospital to the funeral home. Went there the next day to support that process and checked in at the local hospital. And after about 15 minutes on the computer, the clerk said that no such child exists. I said, well, I was here yesterday with the parents, and I didn't see the delivery, but I know what happened. Came back a half hour, same answer. This went on for 3 hours. This process of no child existing. At the end, I shared with them calmly, quietly. I said, well, if you don't bring me the child in a half hour, I'm calling Global. Clerk came back in 15 minutes and said they found the child. And dutifully oversaw the transfer. See, the family wanted to have a funeral for their baby. The community can show up and support them. And I often wondered quietly wondered if that was the right child. There's always private viewing time in the afternoon. And when the family left, I quietly opened the casket. And this is, to me, is important when this moment happens for our newborns. They took the palm prints and footprints of the baby, put it on a card. After I unwrapped baby, I compared the two. It was indeed the right baby. I never told the parents. I've never told them what happened, what it took to get baby back. And when I told the story here a year or so ago, I was told, Dennis, you probably changed the system, because when they register these children, they're not viewed as human beings in some hospitals. I said, well, that's good. It's good to stand ground and resist a bit. The service went well. Family was feeling better after the service, with elders' teachings and always good food. Yeah, thank you.
It's an important story around what people need that might look different than what we need.
Yeah.
Identity. So this is a story about a woman who is being cared for within a health system. Within the initial 3 to 4 hours of her experience, she was asked if she was Indigenous. She hesitated and then shared, yes, I am. After this interaction, she felt that her treatment had changed, and she felt that she was experiencing racism. I think about this all the time. And what's most concerning to me wasn't that she experienced racism. That's concerning, but that wasn't what concerned me the most. What concerned me the most was that she wanted her identity as an Indigenous person removed from her chart. Upon conversation, she revealed that she was white passing, very similar to me, and that by removing her identity as an Indigenous, she believed she would receive better care. Have you ever thought that just being you or just being me would instill such fear, such negativity, and such shame? Identity is so important to who we are.
Yeah, I just wanted to quote the UN Declaration on the Rights of Indigenous People. In part of the report, they released what can happen when governments work together with Indigenous people, and they actually quoted the 4 host First Nations in 2010. And that quote's so important when people work together. And this report, this declaration came out, Canada and the US were the last 2 of the major powers to sign on to that. And when they heard that, they eventually signed, and were eventually basically shamed into signing on, because when people work together, things can happen. Thank you.
Such an important report about the rights, which is always something that comes up in conversation about understanding the rights of Indigenous people. Yeah. Recently, I was involved in a complex situation involving a frail, older patient who was living with her daughter and granddaughter who had mental health challenges. The woman had a lengthy stay, was deconditioned, and while she wanted to go back to her daughter's residence, her daughter was not able to care for her aging mother and her own daughter. The woman had met some targets in her support, in her care, and that supported a discharge. But because the daughter was unable to care for her, she was going to be discharged to a shelter. Despite several conversations between daughter and care team, there was a clear misalignment of expectations. The system unable to provide an equitable approach to discharge because of the constraint, and the daughter feeling unheard and feeling helpless. After an escalation process, a complaint was lodged. The patient was granted an extension, and 2 weeks later, she died in care. Did we offer equitable care for this patient? What was the impact to the daughter and the granddaughter, who will both have to access health system in the future? There are many cases like this. It's not just a one-off. I also believe that our workforce and system is trying to do their best, but are we as leaders making it possible for them? Are we able to give them that space and time to connect with patients and understand what's challenging for them? What would you do if you were her daughter? What would you do if you were the care team?
Yeah, just I'll touch on the hospital system, at least in my since I was born. The local church downtown, the Christian-run church, was the only church local Indigenous people could go to. Even though less than a mile from where I lived on the North Shore, there was an existing hospital. My mother wanted to have my youngest brother, born in 1967, to be delivered there, and she was told no, she had to go to downtown, a place where we weren't allowed to attend as patients or mothers to be. It's changed since a lot, actually. I appreciate that.
Yeah. There has been some good change.
Yeah.
Yeah, absolutely. Safety. The lack of safety is what In Plain Sight report revealed in the 24 calls to action. This domain seems to be the most simple to wrap our heads around. It's in essence what health systems are meant to do, to keep people healthy, to keep people safe from harm, and to provide an experience that creates trust and reassurance. But do you remember the story of Joyce Xwechtaal, a 37-year-old Indigenous mom of 7? She sought care in an emergency department in Quebec and live streamed her experience in care. She was videoed screaming and calling out for help. Staff members are heard calling her names and making discriminatory remarks. Joyce died shortly after that video was taken while in care. Her cause of death was determined to be pulmonary edema. The staff believed she was in withdrawal, a stereotype. The inquiry that was held determined Joyce's death to be preventable, and the Canadian coroner stated, "This is an undeniable case of racism." And so, safety is not as simple as we may believe. Imagine needing to seek care and being afraid that the experience in care may indeed cause more harm.
That's one work I really appreciate, not only with the structures that we saw that are the 70 plus that are in that structure. The IPNs are so helpful in that process. Many of our patients who travel in from rural areas have nobody here. And IPNs help with that, help people navigate through a system that they're largely unfamiliar with, probably intimidating, but they help bridge that process with caregivers and admin.
Yeah, that's great. And that's going to be a great segue. We're going to talk a bit about some of the work that's happening right now. Yeah. So relationality. I was talking to a colleague who shared an experience they had with a physician who was asked to partner with and work on a project. The colleague shared that they had entered into this conversation about a specific Indigenous population who needed critical surgical intervention, but the physician was having difficulty convincing the patient and population to consent to this care. My colleague revealed that the first conversation resulted in more questions for the physician and fewer answers from her. Call number 2, call number 3, the same sort of trajectory, that time for conversation and understanding. By call number 4, she could tell that the physician was starting to get a bit anxious, wanted to move forward in the work and figure out how to get this done. But that person was willing to share, listen, and learn. You know, at one point, that physician had this enlightening moment of understanding what really mattered to the patient and family. They could relate. They understood about fears in the health system, about distrust that was within them. This moment would transform how they approached and provided care for Indigenous people. You know, if that wasn't enough, I inquired about who this was, and I knew this person. I'd had experiences with this person, and I too was a little bit shocked because that person was not known to be necessarily easy. But I had just received a complaint from a patient and family about an experience. And within this complaint was a heartfelt thank you to this physician. How they had cared for them, went to share the kindness and compassion that physician extended towards them. And that the physician exhibited all of this despite a system that could not provide that experience the patient and family were looking for. I just thought, wow, like just through making time to have a conversation and understand and relate, this physician was able to transform how they cared for Indigenous patients and families. Making time.
Thank you. Well said.
So this is the Coast Salish eye. Elder Dennis, did you want to share about that?
The Coast Salish eye represents the eye of the Creator, the eye of our ancestors, and the eyes of our children. And when we make decisions, we think 7 generations ahead and how it's going to affect that 7th generation. And always watching over us are our children, our ancestors, and the Creator. And certainly, as an elder, you tend to have your ear to ground in community and know what's going on. So elders are always watching too. They may not say anything, but they know what's going on. Yeah. Always. Yeah.
So the Indigenous cultural safety education sort of uses this model to reveal the truth of Canada's history that has informed and influenced the present. This 2-eyed model. It is a type of unlearning and relearning truth that will change the course of direction. The same model applies to listening to stories of people and their experiences to inform their current situation and either course correct for future or continue along the same path. Without spending time understanding the story, the history, processes, culture, people, experience, we place ourselves at risk for repeating past mistakes. So I just wanted to share a little bit around some of the actions that we're taking. So Elder Dennis spoke about Indigenous Patient Navigators. Those are really the patient-facing and family-facing people who go and wrap around patients and create a bridge to the care teams. And that's really to enhance the experience and make it safe. So creating safer people, safer places. Professional practice, this is our provider and practice facing team. They go reach out, wrap around providers, and really help them to create understanding and a safe space to ask questions and learn in a really authentic way. And so that is creating a safer people, a safer culture. And our quality, we have Indigenous patient care quality liaisons. So this is perceived harm has been done. They reach out to our practice supports, our experience team, and they really take that restorative approach to healing harm. And so that's our organizational influence, so safer systems. And what is crucial to this whole piece of work is our elders. They reach out and branch out into all of those components of the work and really ground the individuals doing that work, the patients and families connecting in with, and that really does influence the systems. So this is, it's hard to create a model for what the elders program does, because it's more than these circles and it's more than these lists. But this is the best I could come up with. But again, very similar systems and people, supporting an organization and the people within to ensure that Indigenous knowledge, wisdom, and culture is included and valued. Patients and families, supporting patients and families within the health system throughout their health journey to positively influence their health outcome through Indigenous knowledge, wisdom, and culture. So that experience piece. And then program and culture, throughout the health system through Indigenous knowledge, wisdom, and culture, influencing and transforming people, culture, and care through, this is like committee work, influencing policy, that kind of work. It's, like I said, it's really, really hard to understand what the elders do and their impact on patients and families and providers, but it's something I don't think you can put a measure to.
Very difficult. Yeah, for me, I always make it understood with those I work with. What happens there is, and said there stays there. So they have that sense of confidentiality, and then I spend time, if they wish to get to know them, Indigenous country, we always get the Indian nod, you know, okay, where are you from, kind of thing. And it's always understood. And more often than not, I always find a way through friends, family, political figures that we're connected. Indigenous country is a small country. It's not like we do know each other from everywhere, but often when we find that connection, 90% of the time is just simply amazing. There's blood relations, there's political connections. The list does go on, and also some varies from simply a visit to smudging, to cedar brushing, to feather brushing, to storytelling. Some of them love to hear stories because they grew up hearing stories, a lot of the elders that I work with, and young people. So it does vary, and just to touch on the cedar brushing and the feather brushing, it helps pull that negativity, if you will, through prayer, through song, and to let it go, and we take the cedar boughs to the water and let the water take it where it needs to go. Not that I encourage the patients to do the work on their health, but also on their spiritual health to help wake them up on their spiritual growth and their physical growth. It gets very complex.
Yeah, it is complex.
Yeah.
And I think to your point around being connected, I think truly some of it is because you have those same worldviews, those same care for our land and people and relationship and how important that is.
Yeah. Yeah, and once we find that connection, then things go a lot easier. Yeah.
So some of the next steps, you know, for us, our work together, but also for you, is how can you continue this conversation and learning? How can you make time and space? I put that first because I think it seems really simple, but it's so hard to do in our current climate of healthcare. Education, how can we provide Indigenous cultural safety education, understanding those domains of that experience, and approaches to care. So that's our work, but it's also everyone's work. Resources, upscale and spread, who, how, where, when, who should get this kind of, who should be entering into these conversations and get this kind of learning. And then really, a really big piece of work that we are beginning to work on here is this development of patient experience metrics that include experience framework domains, but also those Indigenous culturally safe experience domains, and putting a number to it so that it can talk to our current clinical health system.
Yeah, and for me personally, when I do my work with various different people, various different backgrounds, especially in the cultural safety training, I encourage people to have a good personal wellness program, and they often ask, what's yours? And I share music, ceremony, going to the mountain, walking through the forest, good family support. Back in the day, I'm thinking of going back to a good therapist, just to be support, and yeah, do that openly, clearly, and share.
So this is just a quote for you to read, but really that it's not about a tiki box. It's really about making that time and space, having those conversations, and knowing and committing to that, taking time, and that there is self-reflection and learning in all of our interactions with each other, with our patients, with our elders. Very grateful for you, Elder Dennis. So that's it. This is just for anyone who's at VCH. This is, again, another commitment that VCH has made for VCH employees, an opportunity to donate, and this money goes to support Indigenous patients and families specifically. Sort of speaks to equity. Thank you.
Wow.
Thank you.
Thank you so much, Elder Dennis and Lori. It's just absolutely, I love those stories. I love the meaning behind the stories and the principles that you bring for us to digest, and really appreciate that a lot. I know we just got past 1 o'clock. It was just a fantastic presentation. I know some of you may have to leave. Thank you very much for being here. Again, we'll be staying here till 1:30. By the way, Elder Dennis and Laurie, we have some really fantastic comments in the chat box. Let me start highlighting a few of them. At around 12:42, we're talking about, Laurie, you were saying, how do we slow down? That was a little bit discussion. Is how do we make time when we deliver care to slow down and understand our patients? 4 comments. Love to hear your thoughts. One, Amber was saying that if it's possible in a day, I'll see less patients, but with more care and time for each one of them. So that's one. Jeanette was saying that when we said we have to deliver our care, that's our agenda. But instead, we should really think and acknowledge about our patients. How do we establish rapport and trust and understand what they need? And then Liz says, I think that everyone is human being first. And so you start from there and then move forward. And then M. Gazenta, sorry, M, I don't know your first name. I apologize. The intention is to better understand how we define and measure culturally safe and what we may learn today to welcome better our Indigenous patients in our particular care setting. I welcome your thoughts about those comments about slowing down. And also, Laurie, when you reflect on slowing down, what you think. And Dennis, Elder Dennis, welcome your perspective also.
Did you want to go first?
Sure. Certainly you'll have more experience within the system day to day. And for me, when I've spoken to people that are rebuilding hospitals, is to look at design of the buildings and not only palliative care, but for newborns, to embrace principles locally of putting palliative care, elders care on each side of the buildings, along with the newborns. We believe that's where we come from when we're born, from the sun. Our elders always love to see the sunrise. And more often than not, I know our culture is not alone in this. In both cases, saying so long and welcome to our human beings, our whole families like to show up. And as a teenager and beyond, we were often shoulder to shoulder in the room, wanting to welcome newborns and say so long. Drumming and singing is always important. So I asked them to make the room big, and to people to kind of slow down, and from an architectural point of view, to allow people to celebrate those moments that we all have as human family. Yeah, so it's a good example, I think, of slowing down. Listen to local knowledge.
I like your thoughts around how rooms are constructed, and some of that is just even with our teams. And so can we work in more open areas where we're connecting just in those passing by moments? I think those are opportunities to connect. I think, really practical ways. Eye contact is important, acknowledging someone, trying to know them by their name. When people enter into health systems or healthcare, I think about emerge and triaging, and I think they're coming in because they're scared. So add they're scared, and then add a layer of they're scared of the health system. And so, what's worrying you? That might not be that they have chest pain. It might be, I'm worried I'm going to die, that I'm going to leave my family. But acknowledging what is it that you're worried about? I know it's really hard to make that time, but when we're in such pressure, can you take moments, just a moment, to connect with the person on a human level, and just know that that history of trauma, that's not personal to you, but we have to acknowledge it. And I think those are just really a few important things that I would take, and that I've really learned from Elder Dennis and from this team in the last year is really connecting in and acknowledging, and it's not personal. It's where we're at in Canada today.
I just wanted to share one example, apart from all those intimidating factors that you mentioned, even for now the more lucid patients. Silence doesn't imply ignorance. A lot of us were taught to think twice and speak once. So if there's a long hesitation, just wait. The answer will come. It's a matter of being patient and connecting again. Then they will tell you. Some of them won't stop.
I would just add one thing to that, Elder Dennis, is that stories. This is a storytelling culture. We like to share. It just might take some time, but if you can make that time to hear through the story, you'll hear, about experiences and wisdom and knowledge. Every time I have a conversation with Elder Dennis, there's so much richness in there. I think listening to that story.
Excellent, thank you. I want to share a comment at 12:45. Casey shared with us, I thought so meaningful, and she said, the realization that whether an environment is culturally safe is not determined by us as providers, but by Indigenous patients receiving care. It's not about our own perceptions. So thank you so much for sharing that comment. Sonia was sharing her experience about being the Indigenous Patient Navigator, or IPN. Within Indigenous Health, one of their services is to provide supporting consulting patients and family on their needs. I know, Elder Dennis, you also talked about IPN. Maybe if you can share a little bit about IPN and their place, and how can we as health professionals engage IPN and learn from them, and through them engage our patients. Welcome your thoughts.
Yeah, patients as they enter have an opportunity to self-identify as Indigenous. Historically, in my tenure, my status card was my personal health card whenever I went for service, and certainly times have changed. But I think to access those IPNs, they're expanding as we speak, hopefully, and need to grow more. But they help administer 24 elders throughout the system that do hospital visits, cultural safety training. We also do, a handful of us do end of life ceremony. We could access that probably once every week and a half, sometimes twice a week, for families who seek that support, and through ceremony help say so long. Again, no word for goodbye to a loved one through a ceremonial way. Just to expand on that point, I'm sure a lot of us saw that RCMP officer in the news or watched it. When they're in care, and it's always a matter of discernment spiritually, we believe that our ancestors come when that moment comes, when one transitions. They actually will see our ancestors in the room. I don't know, psychiatry has a field day with that, but it's a matter of discernment for spiritual leaders to say that they're here, who can support that view. And much like to what happened with the RCMP officer when out of service, it is the pallbearer's job to hand that loved one off to the ancestors who have come to take them back home, as it were, to the Creator. So it's a mutual transition. It's usually old people or respected people that always carry the last load.
Thank you. I found out, I'm very glad, I found out M. Gazenkas. M stands for Marnie. Thank you for letting me know. Marnie was thinking, she was saddened by hearing about the white passing. I think, Laurie, in one of your stories, a person didn't want to identify them as Indigenous, thinking that white passing would get them a better experience. What are your thoughts? How can we help ease that journey, or how do we recognize it, or how do we support patients on that front? Any tips for us for that?
Well, I would say I'll share a bit of my experience. Is that that my Indigenous culture was really suppressed as when I was a child, and that was really for safety. My mom, really, pulled us away. And so I think knowing that that is something that people fear, even if they are Indigenous, that they could have fear. That could be scary because that's what we were taught. I would say that's one thing. Understanding that Indigenous people look like any other people. We don't have, there's not a certain look all the time. and that is an impact of colonization itself. And so we should be asking that question and knowing why we're asking that question, because we want to provide supports like Sonia, like the Indigenous Patient Navigator. I know there's a few on here, and so thankful for the work that they do, but that's why we're asking. We're asking so that we can support. We're not asking to collect that information. So I think just acknowledging that there is history there and that every person will come to that with a different experience. Do you have any thoughts?
Yeah, what I've always encouraged at our cultural safety training, and there can be others, is the opportunity for providers to wear a hummingbird on their lapel or their work clothes. When a patient sees that, they'll understand that you may have some insight to Indigenous people or knowledge, or simple as that. It starts the building of trust in the system, and they could self-identify that way. It's a delicate way of letting you know that you understand them and would support them. And that little, I call it regalia, lets them know. And it's important, much like our name badges.
Mm-hmm.
Yeah.
Wow, I love that. Maybe, Laurie, we should have some hummingbirds available from VCH Indigenous for health professionals.
Kendall, everyone who takes ICS gets a hummingbird. So.
Oh, wow.
Get everyone to take it.
Please, everyone, please join. Get the hummingbird. That's like, Laurie at 103 was saying that, thank you to both of you for the image of this important work. Supporting service providers to be safer to interrupt internalized, normalized, socially accepted racism. Laurie, of course, great teacher yourself. Thank you very much. Welcome your thoughts on this, unearthing some of those, or using the special eye to see the internalized, normalized, socially accepted racism, unearth it, fight it, and support our patients. Any tips there? Welcome thoughts.
This comes up at ICS quite a bit. And so there are some really simple things. One is get more education to learn, enter into conversations by creating that safe space with someone. You can ask questions. There is a really brilliant, at the Museum of Human Rights in Winnipeg, they did implicit testing. And so that will just bring your biases right to the forefront. And so in ICS, when we do that education, we talk about bias check. So before you enter in to that interaction with the patient, a family, a staff member, a provider, whoever, that you stop and say, what am I going in with? You have to be real with yourself. What am I going in with that could be a bias? And we call that bias check. And that comes up in ICS all the time.
Yeah.
Wow.
That's hard work, though. That's that self-reflection. And I will say in the ICS model, there's 5 levels: hummingbird, frog, salmon, and eagle. And those are all levels of where you're at in your learning journey. But the 5th one is the circle, and that it continues, and that this is a continual journey. This is an unending path. And so you want to keep doing that self-reflection and with humility. And that's what I would say.
Only thing to add, and when those incidents happen, of course, being human, but we're back to humility. See something, say something. And if somebody else is in the room, it's even better. But if it's one-on-one, still as diplomatically and humbly as you can, say something to help that person grow. Of course, being an elder, you get to say it in many different ways.
I would say too, kind of microaggressions, like understanding what those are and look like, are very helpful, because sometimes we don't even know that that's going on because it's so normalized and socialized.
Excellent. Thank you very much. Minas at 104 said, I'm grateful to learn that I learned more about system transformation call to actions. Following the 7 domains of Indigenous domains of health are the best ways to provide best care to our patients. Sharing this experience was heartbreaking and eye-opening. So just want to reflect that points, and thank you so much for your great work. Lots of really positive comments about, by the way, thank you so much. We're still getting new messages, amazing. Really appreciate the participants giving feedback on these areas. I may be missing some of these, so I apologize if I do. Doug says, when I teach, I like to tell students that healthcare is a people business. So love that. I think is exactly what we need to do. Angela asks, I'd love to hear if you have any suggestions on how Indigenous patients can share the experiences with the healthcare system with the intention of educating healthcare staff. What do you think?
Wow, that's a really interesting question. What I thought of was, I know most all the time there's discharge plans, but perhaps part of that is perhaps through the navigators, they could submit some comments to help everybody grow. Simple as that.
Yeah, I would agree. I think the patient navigators are really this amazing both patient and family support, but they also connect with the providers, but they can offer that any of those linkages to revealing or sharing those stories. We work really closely at VCH with the Experiencing Care team, and they have a patient stories project that we have linked in with, and we are actively looking for Indigenous patient stories. And the reason is because often Indigenous patients and families don't feel comfortable having those conversations. So we are trying to create that culture, and it's one story at a time. So I think understanding those domains, how to interview people, how to ask those questions, how to approach, will slowly begin to open up the doors for that learning worldwide that would really change systems.
Yeah, certainly the opportunity to go across all cultures as they leave the system. And I know it's another cog in the wheel, but it's a consideration as other patients from around the world leave, that they have an opportunity to help the system grow.
Mm. I'm going to dive a little bit deeper into that, if you don't mind, in the co-phase. Let's say if I interact with a patient, I found that there's really very important experience to share. Do I ask for permission for that patient to be contacted by a Indigenous Patient Navigator? Do I should I even raise the subject? Should I wait till the patient wants to share and then invite them to teach us? Obviously, in that particular moment, I learn from my patients. And so the question is, how can that story might be shareable? Any advice there?
Well, being a politician, always mindful of liability, that this is without prejudice. I think we all have each other's best interest to look after. And I know the health system can, from time to time, get indulged with a lot of complaints, but also needs to have the opportunity to show the balance. So be mindful along the way.
Mm-hmm.
Yeah.
And just specifically at VCH, I would say we have email, we have an intake line. All of our Indigenous patients, our goal is that they all get connected with an Indigenous Patient Navigator, and then they can sort of link in with whatever other resources that patient or family need. That's really the calling of the work that they do. And so we like really to say, and Leslie would say this, that no door is the wrong door, and we will figure out how to get you connected. So about the story, Kendall, you can share that with us. And we would hope that patient is connected already. And I think this asking of permission is just so important, and you can do that in a really humble, vulnerable way. This is important learning. I think it should be shared because so many people can benefit from it. So when you come from your heart, I don't think you can go wrong.
Thank you. Thank you very much. And in fact, I encourage all our health professionals, if you learn a story, perhaps from your vantage point, that story has become important. I welcome you sharing that story with all of us too. because I think learning from each other is so important. Doug, thank you for the reference, Journal of Geriatric Internal Medicine on relationship-centered care. We'll make sure that we share that with everybody. Again, lots of thanks to both of you speakers and Elder Dennis. We're learning a lot. Laura says, I long for the day these beautiful and grounding practices are embedded into care naturally and organically for all humans, as everyone should benefit from the wisdom of the Indigenous way of knowing and being. Thank you for all the work you are doing. I'm excited to be a part of bringing culturally safe care for Indigenous people in the VCH. Thank you, Laura. Really appreciate that. And I'm just searching if there's any additional questions. Doug is also saying healthcare providers need to embrace advocacy role a bit more and support patients in all aspects of their life. Advocacy, what do you think, Elder Dennis and Laurie? What type of advocacy would you see we could do or support our patients? Because you already talked a lot about learning experience, internalizing it, practicing it, and creating this safe space. What about advocacy? Any thoughts there?
Wow, I believe in small and big ways we've been doing it. You know, I come from a GP, for example, who used to visit our longhouse when patients needed care in our longhouse, and we're in that season now. It was like a home call that is few and far between, and of course, no energy or not enough resources right now to do so. But back in that day, people took the time to outreach. I know it's an extremely delicate situation now, but taking that time again to slow down and get to know, and then move from there. Again, we're back to a time issue to me, and appreciate the work. And the other one is I see unfolding all the time is our traditional symbols being depicted everywhere. It gives people a sense of grounding and of where they're at, or no matter where you're from. You tend to, as an Indigenous person, get to know where the art's from, where the totem pole's from. It's always respected and honored. Yeah.
I think having an awareness also just helps to bring that perspective, that awareness to whatever the work is that's going on. You might not be the expert, maybe you should be the expert, maybe you connect in with an expert. But having that awareness to just speak up and say, hey, how have we considered this component? I mean, I think that's like a great first step in advocacy. I say that because this isn't, you don't want to come in and do for, because that is just another way of colonizing. But how can you have awareness and really deeply consider and learn and include?
Excellent. While time flies, I'll ask one short question and we'll have to wrap up. Really, thank you. Many excellent questions and comments. So really appreciate that. The last comment, I guess, is you have identified 4 symbolisms or 4 representations of learning leading to ongoing circle. Hummingbird, eagle. Joni would like to see if you can repeat them so we can learn more. I'd love to learn them myself.
Yeah, of course. It's the framework that VCH uses, symbolized by hummingbird, frog, salmon, and eagle. And the 5th one is a medicine wheel representing circle, that the journey continues. So that's just a VCH learning framework that we use. Excellent, fantastic. I guess your website will be able to find those, find that circle, correct? Yeah, website. We have an email. There's lots of ways to connect in for VCH, especially. So please feel free to. Thank you for having me.
Thank you. Awesome.
Elder Dennis and Laurie, thank you so much. Really, on behalf of our participants, thank you so much for sharing your wisdom, taking the time, and also demonstrating your patience and your wisdom to teach us. So really appreciate that a lot. Also, I'd like to thank all the participants. You asked great questions, fantastic comments. What a lovely learning time together. I look forward to our next one is going to be in December. We'll let you know the exact time coming up. But thank you so much, everyone, for taking the time. Have a great afternoon. Have a wonderful weekend. We'll see you, everyone. Bye-bye.
Thank you.
Take care.
Take care. Bye-bye.